The first presentation will be by Adil El Maftouhi, the broad spectrum of anterior segment application with full range OCT Solix.
Thank you, Professor Lombroso, for introducing me. The new upcoming platform from Optoview, Solix, allows, with a full-range technology, the possibility to have a very wide imaging of anterior segment, thanks to the full-range technology using the mirror image. And you can have windows of 18 millimeters to 6 millimeters with additional lens for anterior segment. You can have a very easily a biometry of anterior segment. The biometry is very useful for refractive surgery before phakic IOL, and in glaucoma to quantify the involvement of the crystalline lens rise in mechanism of angle closer glaucoma. We can optimize the sizing choice using a regression formula to compare with the star nomogram with the Nakamura formula. And you use the distance for the scleral spurs to the scleral spurs and the crystalline lens rise. You can have a specific website done by Dan Bernstein, is the ICL-sizing.com to have this formula. And you can answer to obtain sufficient vaulting after ICL implantation, like in this case. And you can have easily this distance to scleral spurs and to check the vaulting after phakic IOL. You can analyze the angle here in the open angle, in the angle closer glaucoma. Here at the left in the concave iris in the pigmentary dispersion, and some cases in goniosynechia. You can check if the iridotomy is non-transfixing or transfixing. And now we can have the whole crystalline lens to the posterior crystalline lens up to the anterior crystalline lens, in this case of nuclear cataract. You can check the intraocular lens here in the beginning posterior capsule opacification, and you can easily see the anterior yelloid and the vitreous. And in other cases of whitening and glistening, causing degrees of vision in this patient, and you can see here the hyper-reflectivity of this IOL. And this another case of a roll-up posterior capsule after YAG laser. OCT may play an important role in a dry eye screening with Solix, with epithelium mapping, with the quantification of the tear meniscus, and now you have the possibility to have a meibomian gland imaging. In this case of patient with a history of LASIK in 2018 and a history of pre-career in 2000, and you can see here the scleral show. And in the initial stages of the dry eye, you can often see the hyperplasia. The most likely hypothesis is dry eyes cause inflammation, and the increases of the pro-cytokine inflammatory participate to the cell proliferation of the epithelium. You can have the possibility to image with en face the meibom, here due to the incomplete blinking on the same case. And you can follow up the dry eye after daily regimen of a warm compress and lid scrub, and you can observe the normalization of epithelium after treatment, and the other eyes, the same thing. You can quantify the OCT with OCT en face. The tear film analysis is the first time. Here, a patient of history of LASIK. And look here, you can see the shadowing due to the lack of tear film, and is more pronounced on the right eye. And you have a corresponding epithelium mapping. The epithelium is more thinning in the right eye. And in this patient, we can also show abnormal visualization of corneal nerve. It's the first time you can see the corneal nerve with OCT. And OCT can be helpful for the keratoconus screening. Here, in the case of a patient with eye rubbing, in epithelium mapping in keratoconus, you observe a thinning front of the cone associated with the donous hyperplasia of epithelium, already described by Dan Runstein with Artemis. Donc now we can have the total pachymetry of 10 millimeters, epimapping of 10 millimeters, another case of keratoconus with a thinning here, and you can see, you can have the stromal mapping of 10 millimeters. And this is the corresponding corneal, classic corneal topography. You can control the vaulting after the scleral lens in keratocone to quantify the clearance of the lens and to ensure there is no contact between the lens and the cornea. And you can analyze the complication of refractive surgery, like in this case. At the left, you have a regular cut, and here you have an irregular cut during the surgery, and it still remains a piece of the lenticle here in the inferior part of the apex. And here the B-scan corresponding, and here the irregular cut. Cogan dystrophy is the most common disease after 15 years old, and with the en-face OCT, you can easily make a diagnosis of Cogan dystrophy with specific folds of basal epithelial membrane. So, in conclusion, full-range OCT of anterior segment allow for no-contact anterior segment biometry, which is helpful in phakic IOL and angle-closer glaucoma. Solix OCT with ETM, en-face OCT, tear menisc analysis and meibomian gland imaging may play an important role in dry eye screening and follow-up. OCT now offers an objective assessment of dry eye. ETM is very helpful for keratoconus screening in combination with corneal topography, and especially in a first keratoconus, and high resolution of en-face OCT of the cornea offer a new perspective in the analysis of corneal disease as well as in the refractive surgery. Thank you for your attention.